Hammer, can you hear me? Okay, good. Yay. The quiz I handed out is take home, so bring it back on Monday. Amber, I'll email it to you so you can bring it back on Monday. You'll be back on Monday, right?
Yes, I will be.
Okay, good. All right. We will begin. All right, so it's as we said before, it's very common for people, students in particular, to think of the valve tissue as being contractile tissue, and it's not. It responds to pressure differences. When the pressure in the atrium exceeds the pressure in the ventricle, the atrioventricular valves open. The transfer of blood then goes from the atrium to the ventricles. When the pressure in the ventricles exceeds the pressure in the atria, the AV valves shut. They respond to pressure. They're not contractile tissue. Instead, they respond to pressure changes caused by the contraction of the myocardium. Same can be said for the semilunar valves. They respond to pressure changes. Relaxation of the ventricles after they have expelled the blood into the great vessels decreases the pressure in the ventricle, increases the pressure in the great vessels. That will cause the semilunar valves now to shut. They are also responding to pressure differences. Relaxation of the ventricles while the atria are filling eventually cause the atrial pressure to exceed that of the ventricles. The AV valves will open, blood will transfer, and then the last 20% of the blood will be pushed into the ventricles by atrial contraction. Ventricular contraction raises the pressure in the ventricle. That will cause the semilunar valves to open. The AV valves will be shut. The AV valve, when it shuts, the pressure that's actually exerted on it can cause the valve flaps to evert into the ventricle. To prevent that from occurring, there are these little tendinous cords. When you dissected a beef heart in A&P, did you do a beef heart in A&P? No? No beef heart? Katie's saying, I think I did. The rest of you are going, no. So some of you did, some of you didn't. You can see these very clearly in the beef heart. In the cat heart, they're really small. They are there. You can see them. They're very tough. In order to cut them, you have to really take a pair of scissors and cut them. You're not going to just take them and pull them out. They're very strong. These little tendons are called chordae tendineae. Those chordae tendineae are going to pull on the valve flaps, make sure they don't evert. Those chordae tendineae are then attached to papillary muscles. These are small extensions of the wall of the ventricles. They contract as the ventricles contract. As they contract, they tug on those chordae tendineae. They provide tension so that as the valves shut, they're not going to evert, they're just going to essentially close a little tighter. If you have a heart attack, and a heart attack damages those papillary muscles, and the papillary muscles will now not contract, that can actually predispose the flap of that valve to actually evert, and that will give rise to regurgitation of that valve. That is particularly prominent in cases of left-sided heart attacks. Most of your heart attacks are left-sided heart attacks. If you have damage of the papillary to the papillary muscles, that can actually predispose you to mitral valve regurgitation. Because of the death of those papillary muscles, they're not tugging on those chordae tendineae. You're not getting the pull when the valves then get pursed together by the contraction of the ventricles. Semilunar valves, same song, second verse. They open and close in response to pressure differences. They are situated in the great vessels. So there is a pulmonary semilunar valve, usually just called the pulmonary valve. There is an aortic semilunar valve, usually just called the aortic valve. As the pressure in the great vessels exceeds the pressure in the emptied ventricles, those valves will shut. Once that blood moves on, those will eventually open up again. The relaxation of the ventricles, as you can read here, will cause the pressure in the artery to exceed that of the pressure in the ventricle because the ventricle is emptied. It's contracted. That causes shutting, and that prevents blood from backflowing from the great vessels back into the ventricle. Otherwise, you get this kind of circus rhythm where blood goes up and goes down and goes up and goes down, and nothing really gets solved. So the cardiac cycle is one of contraction, relaxation, contraction, relaxation. The contraction part is the systolic part, or systole. The relaxation part is diastole. It's the diastolic part. When we talk about systole or diastole, we're referring to ventricular contraction and relaxation. If you don't have atrial contraction, you can actually still live. Your health is compromised, but you can still live. That's called atrial fibrillation. Again, that 20% that's left in the ventricle is usually not a big deal when you're at rest. Where it starts to make its presence known is during exercise. Because during exercise, that atrial contraction becomes really important for extra performance. So your book has this particular diagram of systole and diastole. So the average cardiac cycle, at rest at least, is about 0.8 of a second. 0.3 of a second are spent in systole. Half a second is spent in diastole. During diastole, the ventricles are filling. During systole, the ventricles are contracting. During contraction of the heart, the coronary arteries are cinched down. There's very little blood flow through the coronary arteries during systole. It's during diastole that those vessels open and you get your most blood flow through diastole. Therefore, oxygen delivery to the myocardium really depends on diastole. The right and the left atria are going to contract virtually simultaneously. Given the physical connection between those two structures, that should not be surprising. The signal to beat spreads straight across the myocardium. The ventricles, however, are going to contract slightly off from each other. Right ventricle will contract first. It contracts about 1/10 of a second after the atria contract. Left ventricle will then contract 1/10 of a second after the right ventricle contracts. This is one of the reasons why you can split the heart sounds if you listen to them in the right places. And that splitting becomes more profound under conditions where the left ventricle enlarges. This is pathologic in cases of heart failure, but it is also completely normal under cases like pregnancy. During pregnancy, you get a physiologic enlargement of the left ventricle. You now have to pump more blood through a larger amount of vasculature. You have to keep the pressure high enough in the placenta for oxygen and nutrient exchange to occur. So you get some enlargement of the heart. It's completely reversible. It's not pathologic, but you will tend to have splitting of the heart sounds, and you will tend to have an S3 sound. So whereas the heart sound is lub dub, lub dub, lub dub, lub dub, S3 will sound like Kentucky, 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 lub dubby, lub dubby, lub dubby. And that's called an S3 gallop. Again, during pregnancy, it's completely normal. My wife had one when she was pregnant with our kids, and I listened to her heart to hear it, and I had her listen to it. She said, "Oh no, it's happening to me." I said, "You're pregnant. That's what's happening to you." To which she said, "You did this to me." And yeah, I was sleeping on the couch. No, that didn't happen. But it's completely normal. It reverses soon after you give birth. Where it becomes a problem is during pathology, when the heart enlarges pathologically. And when the atria and the ventricles both relax, you can see that's the case for a good part of diastole. That last part encompasses atrial contraction, but for a good part, the atria are relaxed and they are filling. Some numbers to consider. End diastolic volume, or EDV, end diastolic volume. That is the blood that is in the ventricle at the end of diastole before the ventricle contracts. So the buildup in pressure in the atria causes a pressure in the atria to exceed the pressure in the ventricle. AV valves open, blood will flow merely as a result of pressure changes. Final 20% will add to that EDV, and diastolic volume. That's the total amount of blood in the ventricles at the end, diastole. That's what the ventricle has to pump. The contraction of the ventricles ejects most of the blood, usually 2/3-ish of the blood, from the ventricle into the great vessels. That amount expressed in a volume that you eject per beat, that's called a stroke volume. Stroke volume. The percentage of blood that you pump is called the ejection fraction. The ejection fraction. So the stroke volume divided by the EDV is your ejection fraction. Caleb?
Is urine and diastole.
No, no, that's a good point. No, the heart does grow as you age. And after a heart attack, in fact, one of the numbers that's very important to rehab is EDV. You want EDV during rehab to go up. You want it to, you want it to, sorry, you want it to go down. You want it to decrease. What was I thinking? Up. Up as in not going, increased numbers going down. You want it to decrease because the heart, if the heart is damaged and it starts to dilate, it'll fill more, the EDV will go up. That tells you the heart is actually starting to remodel. You want that number to go down, and that is a measure of your rehab. You want stroke volume and ejection fraction to increase. Yes, yes. Athletes typically, because of left ventricular hypertrophy, will tend to have a lower EDV. They'll tend to fill less because there's just less space in the ventricle. And you'll have a more forceful contraction, so you'll have higher ejection fraction. Is percentage of the blood that's pumped out. So it'll be the stroke volume divided by the EDV. That gives you a percentage because the units will cancel. And you get a decimal fraction, multiply by 100, and you get a percentage. And we went over this in my pharm class, so I'll just share this with you. The average is between 50 and 70% stroke volume. 40 to 50% is borderline. If you're below 40%, you have systolic heart failure. The end systolic volume, that's the volume of blood left in the ventricle after contraction. And during cardiac rehab, you want that number to go down as well. Yeah, ESV. And you can measure these in an echo easily. Consequently, after rehab, you'll get sent for an echo, and the echo will tell you how well your rehab is going. And then the ventricles will relax, and then they will start to fill when the atria fill and cause the opening of the AV valves. So your average cardiac rate is in the vicinity of 75 beats per minute-ish. Your normal heart rate somewhere between 60 and 100. Kids, for example, who take Adderall, or adults who take Adderall, those are amphetamines. Those will increase usually the resting heart rate. It's not uncommon for kids on Adderall to have a resting heart rate in the high 80s or 90s. It was thought for a while that such a heart rate was bad for you. There have been a couple of long-term studies of Adderall, and it seems to not be a problem. So the systolic pressure when the heart contracts in the aorta is around 120 millimeters of mercury. As the blood then traverses through the arteries, that pressure will tend to vary. It will usually, in the arteries, stay kind of high, and then it will start to drop as it gets into the arterioles. When it then gets into the capillaries, it drops even more. And then when it gets to the venous system, it gets very low. In diastole, the pressure in the systemic arteries will go from 120 down to about 80 or so. So the cardiac cycle is expressed in this thing called a Wigger's diagram. A Wigger's diagram will go through the stages. You see on the bottom there, 1, 2, 3, 4, 5, 6. Those are the stages of the cardiac cycle. We'll explain those, then we'll do the Wigger's diagram to show you essentially. So there's 6 stages of the Wiggers diagram, 6 stages of the cardiac cycle. They are 1, isovolumetric contraction, 2, ventricular ejection, 3, isovolumetric relaxation, 4, ventricular filling, sometimes called rapid inflow, 5, diastasis, sometimes called ventricular relaxation, and then 6 is atrial systole. We'll go through each of those. I said those fast. You'll be able to see them on the slides. So stage 1, the ventricles will start to contract. The intraventricular pressure will rise. Because the AV valves are shut, there's no ventricular filling, so the volume is fixed. But because the actual space in which that volume is contained is contracting, the pressure is rising inside the ventricle. That's why it's isovolumetric contraction. That pressure in the ventricle will exceed the pressure in the aorta, or if you're the right ventricle, the pulmonary trunk. You'll eject the blood into the great vessel as the semilunar valve opens, the aortic valve on the left side, the pulmonary valve on the right side. Under normal circumstances, that pressure, at least in the aorta, will be about 120 torr. On the pulmonary side, it'll be about 25 torr. The ejection then begins, and as it begins, ventricular volume will tank pretty quickly. And this constitutes the ejection phase, or the ventricular ejection phase. The pressure in the left ventricle falls because the pressure in the vessel is now greater than the pressure in the ventricle. The semilunar valve will snap shut. That's your second heart sound. And pressure in the aorta will now fall to about 80 torr. Pressure in the left ventricle falls to about zip. Pressure in the pulmonary trunk will fall to about 10 torr. 10 torr. 10 millimeters of mercury. So this is isovolumetric relaxation. Isovolumetric relaxation. The AV and semilunar valves are closed, and this phase will last until the pressure in the ventricles be less than the pressure in the atria. And so now this relaxation, this diastasis ensues. And then eventually the pressure in the ventricles will be less than the pressure in the atria. The AV valves will snap open, and that will now constitute the inflow phase, rapid filling of the ventricles, ventricular filling or rapid inflow. And the final phase will be atrial systole or atrial contraction. That will take that 80%, that 20% of the blood that's left in the ventricles, in the atria, move it into the ventricles. So here is your Wiggers diagram. It shows that ventricular ejection has a rather fast and slow component at the first. So if we look, why did the pen function ever work anymore? All right, so, yeah, right there. So you can see it's pretty fast here. Then it gets pretty slow right here. The fast ejection phase is first. The ventricular pressure is high, so you get very fast ejection. The slow phase ensues, as the ventricular pressure diminishes. At the end of systole, you have the closure of the leaflets here. That's your second heart sound. That indicates the end of systole, the end of the beginning of diastole. And you can see the pressure in the ventricle now is low because whatever's going to be pumped out, you pumped it out. The volume now starts to change over here as the ventricles will start to fill. The pressure, however, is not very high in the ventricle. And then, as you can see, the atria then are going to, you'll have opening of the valve. You have infilling, and then eventually the pressure in the ventricle will exceed that of the pressure in the ventricle exceeds that of the atria. I get atria and ventricle mixed up constantly. And you get filling, and then the AV valves will shut. That's your first heart sound. And now the pressure in the ventricle will really start to soar. And that's the start of isovolumetric contraction. Notice volume doesn't change, but pressure does. And then the valves will, semilunar valves will open, and then you'll see you get transfer of the blood to the great vessel. So the interventricular pressure rises as the ventricles contract, then it falls as the ventricles relax, here to here. And notice what happens to the ECG, which we'll look at a little later. In the ECG, the P wave indicates atrial depolarization. Remember, anything mechanical that happens in the heart is preceded by electrical events. So your systole of your atria is preceded by the P wave. Likewise, the contraction of the ventricle is preceded by the QRS wave. And the relaxation of the ventricle is preceded by the repolarization, T wave. And the first heart sound occurs at the base of the QRS, and the second heart sound occurs essentially pretty much right in the middle of the T wave here. So the semilunar valves remain closed throughout diastole. The atrioventricular valves remain closed throughout systole. The first heart sound occurs at the end of atrial contraction and at the beginning of isovolumetric contraction, once the atrial pressure drops below the pressure that's in the ventricle. And the closing of the tricuspid, bicuspid valves, the atrioventricular valves, will generate the first heart sound. Sometime exercising children, for any of you who do pediatric work, will have an S3 sound that occurs early in diastole. And if you hear an S3 and an S4 sound, that's the S4 sound is always pathologic. Always. Whereas S3 is Kentucky, Kentucky, Kentucky. S4 is Tennessee, 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 Tennessee. So that lub, that's the closing of the valves. It's usually thought that the closing of the valves causes a sign. Most cardiologists, most cardiophysiologists think it's the pressure wave set up by the closing of the valve. Either way, the closing of the valve causes a sign, the sound. Whether you think it's a pressure wave or the valves actually whacking together, either way, closing causes a sound. Closing of the semilunar valves causes that second sound. The semilunar valves are best heard at the fourth intercostal space. Aortic valve is best heard on the right side. Pulmonic valve is best heard on the left side. The AV valve is best heard in the fifth intercostal space. The tricuspid valve is best heard next to the sternum. Mitral valve is best heard mid-clavicular line, fifth intercostal space. That's where you hear that the best. If your heart valves don't oppose properly, you can have a heart murmur. Now, heart murmurs can be completely benign. My dad, for example, had one. Dad had diphtheria when he was very young. It completely wrecked his teeth. He had these brown stained teeth all his life, except when he got older, he got them all replaced. And he was very glad. I remember Mom made these cookies once that were very chewy. And my brother and I sat there and went, oh, these are great. Essentially really hard cookies. And we really liked them. Dad couldn't eat them. They hurt his teeth, which my brother and I said, more for us. But that's just an example of what diphtheria did to his teeth. Well, the high fevers he suffered and the diphtheria toxin also affected his mitral valve. And Dad had a leak, and Dad said, yeah, I had a heart murmur when I went into the Navy. My dad served in World War II. He was in the Pacific Islands. He fixed things. So he never saw combat, but he said Japanese planes went overhead. That's as close as he got to combat. Nevertheless, he discovered he had a murmur, and he let me listen to it one night. And sure enough, instead of it was very subtle, and it was essentially a swishing sound that came from escaping blood as those valves shut. Never bothered him. Dad was a farmer. He was a little guy. He always worked way too hard for a guy his size, and it never seemed to bother him. You can also have a murmur if you have rheumatic endocarditis. Now, rheumatic endocarditis is usually the result of untreated strep throat. So streptococcal pharyngitis is usually called by group A streptococci, usually Streptococcus pyogenes. And this little booger is a gram-positive bacterium that makes chains of spherical cells, but on the outside of those cells is a spiky little protein. That is called M protein. M protein is very immunogenic, and antibodies to the M protein cross-react with heart valve tissue. So this is the reason you go into your doctor with pharyngitis, you get a strep test, and if your strep test is positive, you get treated right away. Because if you wait until after 10 days, typically your body will start to make antibodies against that M protein, and they'll cross-react with your heart tissue. That will cause the heart valve tissue to be inflamed. It will start to swell. And with that swelling, it'll roughen and it'll shorten just a little bit. And that shortening can actually cause the valve to not close all the way, and it can cause a heart murmur. And that is also why some people after a strep infection can get streptococcal rheumatic heart. And that's due to this usually short-lived endocarditis, but it can predispose you to infective endocarditis later in life, particularly if you have dental work. That's why after every dental procedure you get that's invasive, you usually get antibiotics because your teeth turn out to be a very good place for entry of bacteria into your bloodstream. All right, so electrical activity of the heart. Heart muscles are attached to each other. They transfer signals to each other. They work as a unit. Because they work as a unit, they're called a myocardium. Action potentials that originate in one myocardium cell get transmitted to all the others. So they work kind of as a functional syncytium. They work like they're just one cell. The signal to beat originates in the atria, specifically the upper part of the right atrium. There is a patch of cells called the cardiac pacemaker. The cardiac pacemaker is also called the sinoatrial or SA node. These cells can spontaneously depolarize. It's a remarkable capacity that these cells have. So they are capable of generating a so-called pacemaker potential. Their resting membrane potential is somewhere around minus 65 millivolts. They gradually depolarize to about minus 50 millivolts or so. That's their threshold. When they get to their threshold, they open voltage-gated calcium and sodium channels. And these particular channels are called HCN or hypersensitivity to cyclic nucleotide gated channels, HCN channels. The HCN channels open much more robustly when they're exposed to things like cyclic AMP. So here's the electrophysiology for pacemaker cells. Don't confuse this with ventricular cells. This is different for ventricular cells. This is for pacemaker cells. Pacemaker cells only. So once the cell gets to resting potential, automatically you have the opening of particular channels. And this causes the pacemaker potential. This is also known in the literature as the funny current. Funny current. Yes, Jacob, that's an odd name for it, but that's what it's called. Odd name for it. When people started studying these, they said, this is weird, this is funny. And the name stuck, and historically, it keeps sticking. The funny current, the spontaneous depolarization, gets the cells to threshold. At threshold, voltage-gated calcium channels open. Calcium comes into the cell with abandon. The cells depolarize very quickly. Calcium is responsible for contraction of these cells. The calcium channels will close. Voltage-gated potassium channels open. The cells will depolarize quite quickly. They get to resting potential. The voltage-gated calcium channel, potassium channels will close, and the pacemaker potential starts anew. And then it goes over and over and over again. And these are referred to as stage 0, 3, and 4 of the cardiac cycle. Stages 0, 3, and 4 of the cardiac cycle. You have two types of calcium channels that open. T-type channels and L-type channels. T-type channels and L-type channels. The T-type channel is also called a fast calcium channel. The L-type calcium channels are also called slow calcium channels. So they open, calcium comes in. Calcium is required for cardiomyocyte contraction, and the cells contract. This depolarization will then spread via gap junction connections to all the nearby cardiomyocytes of the atrium, and then will spread as well to the cardiomyocytes across the atrium as well. Hence, the atrial myocardium will work as a unit. Then the voltage-gated potassium channels will open. The voltage-gated calcium channels will close. The cell will repolarize. Right after it repolarizes, that pacemaker potential, the funny current begins yet again. Non-pacemaker cells have a very different electrophysiology. So the electrophysiology I showed you is just for pacemaker cells. Non-pacemaker cells do not have a funny current. They also have a threshold at about -70 millivolts. Their resting potential is about -90. So right from the get-go, you can see electrophysiologically, they're very different. These cells will depolarize very quickly. They will also repolarize very quickly, but when they start to repolarize, voltage-gated calcium channels open, and you get a so-called plateau stage. A plateau stage. The influx of calcium is going to fight the outflow of potassium. That's what causes a plateau stage. The calcium is necessary for contraction of the cardiomyocyte. Eventually, the voltage-gated calcium channels will close. You get proper repolarization of the cell, and now the cell is at rest yet again. So sodium, not calcium, will be responsible for the initial depolarization. You depolarize, but the calcium channels open, you get a plateau phase. Then eventually the voltage-gated calcium channels close. You repolarize because of the voltage-gated potassium channel. Eventually they will close. You get to resting, and then you're ready to repolarize again. To depolarize again, excuse me. So you can see the phases are labeled 4, 0, 1, 2, 3. Remember, your pacemaker cells have 0, 3, and 4. So they are able to quickly depolarize, they quickly repolarize, and they have a resting stage. They don't have the 1 or the 2 stage. They go 0, 3, 4, whereas the non-pacemaker cells have 0, 1, 2, 3, and 4. So stage 4 is resting potential -90 millivolts. They'll eventually get to threshold. They will depolarize very quickly, stage 0. They repolarize to about 0. Voltage-gated calcium channels open. You get the plateau stage, slow repolarization. You get that fight between calcium and potassium. You can tell calcium coming in, potassium trying to leave. Eventually, those voltage-gated calcium channels close. You get full repolarization. Voltage-gated potassium channels close, and you're at resting potential then, which is -90. Cardiomyocytes show something that skeletal muscle cells don't do. This is called calcium-induced calcium release. Calcium-induced calcium release. As extracellular calcium moves rapidly into the cardiomyocyte, that extracellular calcium in the cytoplasm induces the cardiomyocyte to release its calcium stores. Calcium-induced calcium release. That will cause a gush of calcium into the cytosol that will induce cardiomyocyte contraction. Calcium-induced calcium released doesn't occur in skeletal muscle, only occurs in cardiomyocytes. So you have the T tubules, transverse tubules. You have voltage-gated calcium channels. They will open in response to depolarization. Calcium enters a cytosol. Calcium release channels are in the membrane of the sarcoplasmic reticulum. They open. Calcium moves into the cytosol, very rapidly causes contraction. Then calcium is brought back into the sarcoplasmic reticulum by the circa. The sarcoplasmic endoplasmic reticulum calcium ATPase, circa. Sarcoplasmic reticulum calcium ATPase, or circa. Pumps it right back in very rapidly. Gap junctions will spread the signal to contract through the myocardium, but you got a problem, don't you? You got a fibrous skeleton between the ventricles and the atria. How are you going to get that signal to beat down to the ventricles? You have a conduction system that goes from the atria through the septum, around the apex, into the walls of the ventricle. Here is that conduction system. Signal is transmitted through the atria to this conduction tissue. This is the atrioventricular node. It's at the base of the right atrium. That signal then goes into the septum. This is called the bundle of His, otherwise known as the AV bundle. The silly mnemonic I learned when I was studying this as an undergraduate was the head of the snake says His, the bundle of His. So it looks like a snake, kind of, the head of the AV node. The snake says His, not his, His. Then it branches, left and right bundle branches. They go through the septum. When they get to the apex, they swing around. They're going to have lots of little branches. They're going to give branches to the papillary muscles. They give branches to various parts of the wall of the ventricle and the apex. They'll go right up, and then they'll stop right up at the top of the ventricle. These branches that then branch to the apex and throughout the myocardium of the ventricle, those are called Purkinje fibers. So we go SA node, atrium, AV node, AV bundle, right and left bundle branches, swing around, Purkinje fibers, boom. The AV node depolarizes because of calcium. It's calcium base. Consequently, there's going to be a little pause when the signal gets to the AV node. This pause is actually really important. If you don't have that pause, the ventricles can potentially contract, boom, right after the atria before they're full. Little pause, and that pause is really important. So near the inferior portion, very close to the septum, you have the AV node. You go through the bundle of His. That'll conduct it through the fibroskeleton, down through the septum, around the apex, then into the walls of the ventricles, and then into the Purkinje fibers. The action potentials will spread very quickly across the atria. In fact, there is a bundle of conductive tissue in the atria that's called the Baukeman bundle. That'll transmit the signal across the atria. It can be very fast. When it gets to the AV node, it's going to really slow down because of that calcium-dependent depolarization of the AV node. Then it gets to the bundle His and it goes really fast, 5 meters per second. And because it's got to go a little bit further in the left ventricle, because the left ventricle is thicker, it's going to cause the left ventricle to contract a tenth of a second after the right ventricle contracts. This is also important. That way, you don't get blood going up those two great vessels at the same time. It goes a little bit like this, because when that blood enters the great vessels, they expand. If they come into the same time, they're going to have a traffic jam. That tenth of a second delay actually ends up being very important for the transfer of blood into the great vessels. And you can see this depolarization through the skin using electrodes you put on the skin. We saw that in our lab. And this is the ECG. So here is the action potential of the ventricular cardiomyocyte. Here's your atrial depolarization. Here's your ventricular depolarization. Matches very nicely with the quick depolarization, quick repolarization, and quick depolarization of the ventricle, QRS. And then the fast repolarization correlates very nicely with the middle of the T wave. And that is ventricular repolarization, the T wave. You have several intervals that are important. For cardiology, you have the QR interval. So that's the crest of the QRS complex with the beginning of the P wave. You have the ST interval. The ST interval, that ST interval is from the end of the QRS complex to the end of the T complex. The QT interval starts at the start of the Q to the end of the T. There are several drugs that lengthen the QT interval, so that ends up being a very important measure in cardiology. And then the distance from the start and end of the QRS complex, that's very important because in heart failure, very often the QRS complex will start to elongate. And it also tells you if your tachycardia is supraventricular or ventricular. In ventricular tachycardia, this will tend to be elongated. In SVT, it tends to be very small, usually still. So P wave, as we said, that's the signal you get from the atria. Different leads, depending on where they are, will show different amplitudes for that because they have different distances from the P wave. QRS and T waves, those are ventricular, of course, and the deflection you get depends on the position of the electrode. The signal goes down and up like this. If your electrode is here and the signal is going towards the electrode, it'll be positive deflection. If it's going away from the electrode, it'll be a negative deflection, or it may be positive and then negative. So it may be near or something like that and what have you. And this simply shows you as the signal propagates through the heart, you get your P wave followed by your QRS complex. And then as things relax, as you start to get repolarization of the ventricular myocardium, you get your T wave. Remember, I'll say it again. All of your mechanical events in the heart are preceded by electrophysiological events. All of them. Are there any questions about how the heart works, how the heart works with the blood vessels, anything like that? If there aren't, you know what? I'm just going to let you go right here. We won't start the next. We'll do cardiac output after the test. Uh, wait, no, sorry. I'm getting my classes mixed up. On Monday, and then I'm pathetic. We'll do cardiac output on Monday, and then that should finish cardiac portion. And then we'll move on to the respiratory system. Your test is Monday. Okay. All right. I was right, and I thought I screwed that up. Okay, I was right. Never mind. This won't be on the test. No, 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 no. Endocrine system, right. Up to the endocrine system. Cardiac system is not, vascular system, it's not on this test. Lauren? No. Amber, you sent an email with questions?
I did, but I can send it again.
I haven't checked my email all day.
I sent it like late last night.
Let me check my email really fast. Just see if I got it. And let's see. Oh, it's a Google document. It's a Google. Let me see if I can actually open the Google document. Yep, I can open the Google document. Okay, yeah, I got it. I got it. That'll make test writing so much easier. Oh, thank you. So it'll take me minutes instead of hours to write the exam. Freaking rific. All right. I will see you all on Monday. Yeah. And Lauren, I will contact them. Okay.
Is this the quiz I didn't get?
Yeah, pick one up. Okay, Amber, you have any questions?
No, thank you.
Okay,
Sorry about this morning.
you have a good weekend, okay?
Thank you. You too.
All right, bye.